Hello and welcome. I'm Don Renfrew, and for the next hour or so, I'm going to be speaking on contrast and radiation exposure. I'm a radiologist with the Radiology Associates of the Fox Valley. We're a private practice radiology group of about 30 radiologists that covers 9 hospitals in upper central Wisconsin. This talk is for primary care practice providers, and this talk is basically aimed at anyone who orders radiology studies through a radiology department or outpatient imaging center. The idea is that I'm trying to provide some useful information for medical practitioners who make use of radiology services. There's a lot of things that are helpful in terms of radiology studies, in terms of generating a diagnosis and helping you care for your patients. And this talk actually kind of looks at some of the harm that may be caused by radiology or radiology exams. The primary care practitioners and people ordering radiology studies include a vast number of different individuals in the United States. Many physicians, including family medicine physicians, internal medicine physicians, and emergency room physicians. It also includes primary care practitioners such as physician's assistants and nurse practitioners. In this study, this talk, I'm trying to aim it toward all those people and give them some very basic information about what they may need to know about the potential damage and problems caused by contrast and radiation exposure. I practice in Door County, Wisconsin, in a small rural hospital, and of course, as a medical director of the radiology department, issues with respect to radiation safety and contrast administration do come up relatively frequently. You have a lot of imaging exams that you can order as a healthcare professional, and many of these use radiation and contrast material. Of course, ultrasound and MR imaging do not use radiation. I will talk about MR contrast material today, but I'm not really going to talk very much about ultrasound. Ultrasound does impart a small amount of energy into the biological system. In general, ultrasound is not, the degree of risk and the problems associated with the amount of energy when you use ultrasound are so low that generally they're sort of assumed to be zero or so close to zero that they're hard to measure. The one exception to that is medical ultrasound done for early intrauterine pregnancy or even regular intrauterine, later on intrauterine pregnancy. And in those cases, there is some effort expended to try to minimize the energy, but basically the amount of energy used in radiology studies in ultrasound is pretty small. Of course, in lithotripsy, when you're trying to break up a stone, the amount of energy that you can bring to bear on the inside of the body with an ultrasound machine is actually quite large, but for diagnostic purposes, it's pretty small. So, typically you or your patients or both may want to know the risks and benefits of the procedures, and I do give a number of lectures on the benefits of these procedures, such as diagnostic studies to figure out what the cause of a patient's headache is, or what the cause of hematuria is, or what the cause of abdominal pain is. And you sort of know that, or you can have access to those lectures or textbooks that tell you what the upside, if you will, of a radiology study are. This talk is then going to sort of focus on some of the downsides. So I'm going to briefly review in broad terms the risks of contrast material and radiation exposure. Now, the profession of radiology in general, and most radiology departments will go to great lengths to limit any damage that they cause. Broadly speaking, the risk from contrast material and radiation exposure on a per procedure basis has decreased through the years. But the problem is the number of procedures keeps increasing through time. So the global risk to all patients from all these procedures is actually getting greater because of the huge number of procedures that are done nowadays. In addition, for any given individual patient, there may be some pretty significant risks to be had. So my 4 points today are as follows. And again, these lectures the lectures that I give are typically set up so that what I'm trying to do is to emphasize a certain number of very basic, straightforward points. I mean, there's going to be a lot of detail supporting these points, but the main points that I want you to remember 3 months from now, 6 months from now, will be on these red slides. And I'm going to repeat them at least 2 or 3 times through the lecture. So the main points again, point number 1 is that contrast-induced nephrotoxicity has probably been overestimated. With current contrast materials, that risk is pretty low. Idiopathic hypersensitivity reactions, in other words, somebody having breaking out of hives, having laryngospasm, having their throat close off, needing intubation, all that stuff, that's really rare. Those require rapid recognition and treatment, and that's sort of an N, of course. Gadolinium containing MR contrast, that should be avoided in patients with renal failure. And again, all these points I'm going to discuss in some detail in this talk. Radiation exposure has become a significant concern, especially in young patients undergoing repeated CT scans. And note that this is a category that didn't exist 50 years ago. I mean, nobody underwent repeated CT scans 50 years ago. Even 20 years ago, repeated CT scans and the kinds of scans, the scanning and the broad use of scanning we're doing now weren't there. But it's now a significant concern, and I'll talk about that. So, the first point, contrast-induced nephrotoxicity. Probably, in general, if anything, overemphasized a bit. Okay, now why do I say that? Let's look at a little bit of data and some studies. Now, if you're going to try to figure out when you administer contrast material, it has caused any renal damage, you're going to have to figure out how to measure renal function. Now, you can get genuine creatinine clearance by administering and then measuring excretion of substances such as inulin, iothalamate, iohexol, and DTBA. But these measurements are not routinely used. Current clinical measurements are proxies for genuine creatinine clearance, and as proxies they have problems. Creatinine clearance generally requires impractical collection of urine, and it really represents the upper limits of the glomerular filtration rate rather than the glomerular filtration rate itself. Okay. Now, serum creatinine is going to be your most widely used measure of function, which isn't really function, of course, but the problem with serum creatinine as a proxy for renal function is that there are a number of problems. One of which is it varies between laboratories. In other words, this laboratory in my hospital versus the one down the road, the one across town, the one in Green Bay, the one in Madison. The measurements of serum creatinine may vary by as much as 0.3 milligram per deciliter, and it may increase after eating a large amount of protein. That 16-ounce ribeye that tastes so wonderful. It may increase your serum creatinine by as much as 0.2. Creatinine also varies with weight, age, and sex. Furthermore, small changes in your serum creatinine, especially when the serum creatinine is low, like when you're normal, imply large amounts of damage. In addition, changes in creatinine may lag behind your renal damage by several hours or even days. So the creatinine you measure right now may not show you the damage that the kidney had 4 hours ago, because there's this lag for that to accumulate in the serum. So the bottom line is the significance of a serum creatinine value of 1.3 in a young, slender woman who had a creatinine of 1.1 yesterday is completely different than the creatinine of 1.3 in an elderly, obese man who had the same value for the last 3 years. So you have to put serum creatinine in context. Now, one method of compensating for some of the shortcomings in serum creatinine as a measurement of renal function is to estimate the glomerular filtration rate. And this can be done by widely used the Cockcroft-Gault or the MDRD, which is a modification of diet and renal disease study equations. And those take into account age and gender and body size. The problem is that the equations are really only valid if the creatinine is stable. And in the evaluation of acute renal disease, age and gender and body size are not going to change acutely. So what does that mean? That means that estimated glomerular filtration rate is going to simply reflect changes in serum creatinine anyway. So compensating for the serum creatinine by using estimated glomerular filtration rate won't save you when you're looking for acute changes. The other thing is that serum biomarkers like cystatin C, while they show promise, aren't really in current clinical use. So we're stuck with serum creatinine as a proxy for renal failure or renal damage. Now, despite all these difficulties of measurement renal function, radiologists still usually try to take renal function into account when they're administering a contrast material. Radiology contrast materials have undergone tremendous evolution. It's undergone tremendous evolution in the past 50 years. And drug companies have competed and continue to compete to provide less toxic products in the marketplace and garner more of their market share. That's just business. So what are some of the contrast agents? Here, this table lists contrast agents, and the ones listed at the top of this table are going to be your older, higher osmolar, and no longer routinely used contrast agents. And they've been replaced by the low osmolar or isosmolar contrast agents at the bottom of the table. At least in the United States, the non-ionic low osmolar contrast agents, or LOCM, have supplanted those older ionic contrast materials. The latest product is an isosmolar contrast. Claims about the relative nephrotoxicity of these different substances are many times driven by marketing, and they're often confusing and conflicting. But before we get into A versus B in terms of low osmolar, isosmolar, let's look at another issue, and that is this is going to add to the confusion even further. There's a recent set of articles, such as this one by Rao as the first author, and these indicate that the risk of contrast-induced nephrotoxicity may be overstated. These guys, Rao and Newhouse, reviewed over 3,000 articles regarding contrast-induced nephrotoxicity. They only found 40 dealing with the IV injection of contrast material. A lot of articles on contrast-induced nephrotoxicity deal with intra-arterial injection, particularly cardiologists or cardiac studies, with contrast injected into the heart or aortic root or coronary arteries, or all three. Now, in the radiology department, when you're having IV contrast for abdomen or pelvis CT to follow up cancer, or for chest CT to rule out PE, that's really not the same as having an intra-arterial catheter and a large bolus of very rapidly injected contrast in terms of the load of contrast that the kidney sees. And Rao and Newhouse knew this, and they tried to take that into account by kind of throwing out all those articles that dealt with contrast-induced nephrotoxicity with IV injection. Of course, you got to take that and put that in context too. So what I'm going to talk about with these articles has to do with IV injection, and those are actually much more frequent than the intra-arterial injection. I mean, how many IV injections of contrast are there versus how many intra-arterial contrast? There are a lot more, and most of the time in radiology department, we're not doing cardiac catheterization and injecting large amounts of contrast into the heart. We may on occasion inject large amounts into the aorta, but compared to the number of IV injections, it's minuscule. So let's concentrate on the IV injections here for a few minutes and see what these guys found. So they only found 40 out of 3,000 articles that dealt with IV injection of contrast, and only 2 of these 3,000 articles dealt with that had IV injection talked about. Only 2 of these had a control group. In other words, they had a group of patients that were injected with contrast and a group that weren't injected with contrast. These two studies found no difference with respect to acute kidney injury in the injected and in the non-injected patients. Now that sounds kind of weird, but let's talk about this a little further. In a subsequent publication, one of these 2 authors, Newhouse, went ahead and he reviewed the records of over 32,000 hospitalized patients who didn't have any contrast material. Now these patients had sequential serum creatinine measurements. They had these taken, and what Newhouse found was that there's all kinds of variation in serum creatinine, increases, decreases through time. The extent of the changes would have led many of these patients being classified as suffering from contrast-induced nephrotoxicity. In other words, the bump in the serum creatinine means, up until Newhouse and these other guys started writing about it, if you had contrast and your serum creatinine went up, the assumption was, well, it was the contrast that made the serum creatinine go up. Well, what Newhouse said was, serum creatinine can go up and down and go sideways for all kinds of reasons, including IV injection of contrast material. Why are we blaming the contrast material? So the point was that in this set of patients, there were all kinds of changes and variations in serum creatinine through time. And as a matter of fact, some articles even suggest that contrast material may have a protective effect on the kidneys, which is really a bizarre and contrary to most of the stuff that we've heard and learned over the last 50 years about contrast. But certainly what Newhouse found was that a lot of times, without any contrast, that creatinine is going up and down. Okay. So here's another study, this one by Bruce and others, and what did they look at? They looked at contrast-induced nephrotoxicity, or bumps in serum creatinine, in 3 groups. They had a control group. They had patients receiving a low osmolar contrast material. Remember, that's the one in the middle of that table back there. And then patients receiving an isosmolar contrast material. Now, some of those patients had elevated creatinine, and serum creatinine concentrations below 1.8, then the incidence of acute kidney injury was similar in all 3 groups. With higher serum creatinine is over 1.8, there was a difference between the particular low osmolar contrast material they used in this study, which was iohexol, and the control group with a small but statistically significant increase in serum creatinine in the low osmolar contrast, but not between the isosmolar contrast. In other words, to summarize, this particular study found that at creatinines under 1.8, the control group and both the isosmolar and low osmolar contrast were the same. At higher creatinine concentrations, the isosmolar seemed to have an advantage over the low osmolar, but there wasn't any difference between the isosmolar and the control. And that's intuitively kind of what you'd think. Wouldn't isosmolar be better than low osmolar? And that's what this study supported. However, to add to the confusion, that hasn't been necessarily completely supported by other studies. Now, there's your natural question would be, is the key to contrast-induced nephrotoxicity the osmolality? In other words, are isosmolar contrast materials just as safe as saline and low osmolar contrast materials almost as good? Well, maybe not, because there's been 2 large, really large, randomized multi-continent studies, and they were known as the IMPACT and the PREDICT studies, and those are acronyms for the full names of those studies. And these studies found no difference between another low osmolar contrast material. Remember, there's several low osmolar contrast materials out there on the market. In this case, they were studying iopamidol rather than iohexol, as the earlier Bruce study did. And they were comparing iopamidol with the same isosmolar contrast material, irodixonol. The rates of contrast-induced nephrotoxicity in patients with an elevated creatinine, that was the IMPACT study, and elevated serum creatinine and diabetes, that was the PREDICT study. They compared those 2. Now remember, diabetes in the PREDICT study, that's an independent risk factor for contrast-induced nephrotoxicity in addition to your high creatinine. At any rate, a meta-analysis stated iodixonol or isosmolar contrast material is not associated with a significantly reduced risk of contrast-induced nephrotoxicity compared to all the low osmolar contrast material together. These studies were not randomized controlled by saline or something like that, but they did look at low osmolar versus isosmolar. All right. So Ellis and Cohen in this article in AJR talking about contrast-induced nephrotoxicity, they offer an excellent summary. This is a perspective article, and it's published in AJR. And what they noted is that given the frankly conflicting published results, opinion varies, not only regarding the likelihood of contrast-induced nephrotoxicity, but also regarding prevention and treatment of contrast-induced nephrotoxicity. Indeed, the recommendations offered in this article and one of the most frequently used clinical sites, the UpToDate site, where the Rudnick and Tumlin talk about contrast-induced nephrotoxicity, there's variance between what they recommend to do for contrast-induced nephrotoxicity. So let's talk about what do you do with all this data? How can you make sense of this? What does this mean to you as a clinician ordering a study? How do radiology departments deal with this? Well, recognizing that this is an evolving topic, it should be noted that there's really little controversy regarding the administration of low osmolar contrast materials in patients with normal renal function. It's assumed that patients with normal renal function are at very low risk for contrast-induced nephrotoxicity, and that no preventive measures need to be taken in this category of patient. In patients with an elevated serum creatinine, radiology departments do vary. Most are going to routinely evaluate serum creatinine, especially above usually a cutoff like age 60 or age 55, or if there's some sort of history of renal disease. And they're going to use that serum creatinine to identify those who might be at risk for contrast-induced nephrotoxicity. Now, for those with an elevated creatinine, and what elevated is somewhat arbitrary and varies, but one alternative is to offer a hydration. IV hydration is generally felt to be better than oral hydration. And then you can hydrate with either normal saline or bicarbonate. You can do that prior to and following the procedure. There's a relatively benign, cheap, and over-the-counter antioxidant mucolytic called N-acetylcysteine or Mucormyst. That may also be administered prior to and following the procedure. But the necessity and efficacy of any of these interventions remains controversial. So your radiology department may do one thing, and the one across the street in the next town, they may do something else. In general, they'll probably do something to measure serum creatinine and to address the situation. So how does all this knowledge help you as a primary care provider? Well, in general, you may want to know how your radiology provider deals with this situation and confirm that they use low osmolar contrast or isosmolar contrast. In addition, which is generally universally used in the US, but you may want to ask anyway. In addition, you may want to inquire whether they routinely screen for renal insufficiency by checking serum creatinine, whether they routinely pre-treat patients with an elevated creatinine with either hydration protocol of some variety or the N-acetylcysteine. This knowledge may also help you when a radiologist or a radiology technologist calls and asks you what to do with your patient because you schedule them for a contrast injection because of a CT, and now even though the radiology department would usually use ID contrast, your patient has an elevated creatinine, what do you want to do? And you can use this knowledge to help you formulate a response to that question. I guess the other issue is in patients who have an elevated creatinine, you might want to talk to the radiologist about the necessity of injecting contrast or review other diagnostic possibilities like non-contrast CT, ultrasound, non-contrast MR, and I'll get to why it's non-contrast MR in a second, and nuclear medicine options. And there are always options for imaging. You may be able to get the necessary diagnostic information without injecting contrast by changing the method of imaging. Finally, in those patients who develop what appears to be contrast-induced nephrotoxicity after a contrast injection, in other words, they've been given contrast, their contrast comes up, it's probably reasonable to think about searching the patient's history for other alternative causes of acute kidney injury, either pre-renal or acute tubular necrosis, given the recent information we have about the relatively low likelihood of genuine contrast-induced nephrotoxicity and the fact that bumps in creatinine can happen for all kinds of other reasons. In those patients who do have genuine contrast-induced nephrotoxicity, which you can decide on the basis of elimination of other causes, it's usually a transient, short-lived phenomenon. Return to normal renal function is usually faster than with other causes of ATN. All right. And as I said before, as I alluded to just briefly there, other procedures, if you've got elevated creatinine don't include contrast-enhanced MR. The downside of injections of patients with renal insufficiency in MR is way worse than the downside of injection of CT contrast. And I'll talk about that in a few minutes. So the bottom line is contrast-induced nephrotoxicity has probably been overestimated. With current contrast materials, it's pretty low. So what's the next point? The next point is idiopathic hypersensitivity reactions to contrast are rare. They do require rapid recognition and treatment. Now, reactions to the contrast material in general can be categorized as idiosyncratic hypersensitivity reactions and chemotoxic reactions. Chemotoxic reactions include contrast-induced nephrotoxicity that I just talked about. They also include vasovagal responses, which is usually the most common kind of reaction, frankly. They include seizures and arrhythmias. And I'm not going to talk about, other than the contrast-induced nephrotoxicity, any of the chemotactic reactions further. What I am going to talk about here a little bit is idiopathic hypersensitivity to contrast. Now, what happens when you have idiopathic hypersensitivity reaction to anything, including contrast? Well, things that can happen include itching, urticaria, angioedema, bad things like laryngospasm and bronchospasm, hypotension, really severe things. And these vary from very mild, which are seen in less than 10% of patients injected with low osmolar contrast material, to fatal, somewhere between 1 in 10,000 and 1 in 100,000 fatal reactions. Note that the transient, mild, minimal kind of reactions have decreased substantially with the use of low osmolar and isosmolar contrast compared to the contrast materials of yesteryear where we used high osmolar contrast. Those things produced a lot of minor reactions, whereas the low osmolar contrast provoke much fewer minor reactions. As far as we can tell, fatal reactions, which are rare, 1 in 80,000, 1 in 100,000, somewhere like that, they probably haven't changed much. So the low osmolar contrasts have not been a panacea across the board. They've gotten rid of some of the lesser reactions, but you can still die. You can still die from having contrast material. So the reactions, whatever they are, should be recognized immediately by whoever injects the patient with contrast material. And radiology technologists are trained to recognize these reactions. Treatments for the reactions are usually done in the radiology department at the time of the reaction, either by the radiology tech, the department nurse, the emergency department, the code team. You know, if the ante goes up, the radiologist might be involved. Primary care practitioners, frankly, will really rarely participate in these events because they're in the radiology department and they need to be taken care of immediately. Treatment is as for other hypersensitivity reactions, where if it's a minor reaction, you can treat with reassurance and antihistamines. More drastic measures for the bad reactions include, but are not limited to, IV fluids and oxygen, epinephrine, IV steroids, pressors, the full court press for the bad reaction that you rarely see, but it's life-threatening. Now, while your usual primary care provider may never witness or treat an idiopathic hypersensitivity reaction, the issue may arise for primary care providers in two scenarios. If your patient has had a prior contrast reaction, then it's going to arise. Also, if the patients have a history of asthma or atopy, it may arise. In patients who have a so-called quote history of allergy to contrast material, the first thing you need to determine is what really was that response. If the patient has had an obvious anaphylactic reaction, which required intubation, which required treatment with epinephrine, which required cardioversion or hospitalization or a trip to the intensive care unit, it may, the best thing is probably to avoid ever again using at least that specific instigating contrast. Whether you can use some other contrast, you really have to think about that long and hard. And you're certainly going to use precautionary pre-treatment like oral steroids and antihistamines, typically divided into several doses on the day prior to and the day of the exam. If the patient had a flush sensation or nausea or vomiting in response to contrast injection, this is likely a mild chemotoxic reaction rather than an idiopathic hypersensitivity. And these don't place the patient at any additional risk for an idiopathic hypersensitivity reaction. They're just chemotoxic reactions, and they're not they're not going to require pre-treatment or any alarm. This leaves you with a large group of patients somewhere in the middle who have minor idiopathic hypersensitivity reactions, like some sneezing and a few hives and some itching. And the approach to these patients vary a lot. Some people say never give those contrast to those patients again. Other people say you can ignore that event and pretend like it never happened. And there's everything in between. Switch contrast, pre-treat with steroids, etc. There's not really a good consensus as to what the appropriate response is in those patients with minor idiopathic hypersensitivity reactions as to what to do next time. Now, in patients with asthma and atopy, it's a little less confusing. These patients do have some additional risk of an idiopathic hypersensitivity reaction. It's probably about 5 times higher for asthmatics than it is for someone without asthma. But in general, the recommendations are not to pre-treat these patients. They should be given low osmolar contrast or isosmolar contrast. But that's nearly the universal routine practice anyway. So despite the widespread misconception of previous reaction, so in general, your asthmatics and your people with atopy, you can kind of just go about business as usual with them. There's one thing to note, and that is there's a widespread misconception out there. And that's that if you've had a reaction to fish or shellfish, then you're going to have some increased risk for a contrast reaction. It's kind of a little bit true in one sense, and that is if you have reactions to stuff, including shellfish, then you're at slightly increased risk, but not an increased risk in the sense of needing pre-treatment or needing to avoid the contrast. There's a mild gentle increase to anybody with allergies or asthma in general, but the shellfish thing is a misconception. It doesn't place you at any specific or specific additional risk for contrast material. Okay, so that takes me through topic number 2. Idiopathic hypersensitivity reactions to contrast are rare. They require rapid recognition and treatment. How about gadolinium? Well, gadolinium containing, those are the MR contrast materials, those should be avoided in patients with renal failure. A little more than 10 years ago, maybe 15 years ago or so, IV MR contrast compounds containing gadolinium were thought to be almost completely benign. They were administered, especially when administered in routine doses, they were looked on as a godsend for evaluation of the arterial tree and kidneys in patients with renal failure when there was a need to avoid iodinated contrast because of the concerns about contrast-induced nephrotoxicity that I got talked about earlier today. We've progressed from the first case reports regarding nephrogenic systemic fibrosis to the point where tort attorneys are trolling on television for these cases in less than 15 years. Really a remarkable phenomenon. So what in the world is nephrogenic systemic fibrosis? Well, NSF is a really nasty disease. It consists of thickening and hardening of the skin with expansion and fibrosis of the dermis. It occurs essentially only in patients with renal failure. Almost all these patients who have NSF have been injected with one of the gadolinium-containing MR contrast agent. Conversely, between 2.5% and 5% of those patients with renal failure will develop NSF. These are dialysis patients. Since there's no way of predicting whether a given renal failure patient will or won't develop NSF after you give them gadolinium, there are very few circumstances where it makes sense to give gadolinium to patients with renal failure. NSF doesn't really have any good treatment, and it's really a nasty disease. So you really don't want to give gadolinium unless you absolutely have to. If you decide that you really have to for some reason, the recommendations are to use gadolinium, which is one of the subtypes of gadolinium that you can use, gadolinium-based contrast material. And you want to use it in the lowest dose, and you want to follow it immediately with dialysis. But in general, you're better off never using it. Now, for patients who aren't in renal failure but do have an abnormal estimated glomerular filtration rate, there really isn't a consensus on what you're supposed to do. The risk of NSF seems to be orders of magnitude lower for those patients with an estimated glomerular filtration rate of more than 30 milliliters per minute compared to those with renal failure. And there's probably little, if any, risk if your estimated GFR is greater than 60. So that's basically the upshot. Renal failure, I really want to avoid giving gadolinium-based contrast. For those with normal renal function or renal function down to 60 milliliters per minute estimated GFR, you're probably okay. Down to 30, you gotta start asking questions. Okay, so that's gadolinium. Now, the fourth point here, radiation exposure. Well, radiation exposure has always been a significant concern, but it's really mounted to a much greater concern, particularly recently, particularly in young patients undergoing repeated CT scans. Radiation exposure in the US. The average amount of radiation exposure in the United States doubled between the early 80s and 2006. And that was largely because of radiology, especially the increase in CT scans. In the early 80s, about 3 million scans per year were done. In 2006, 67 million CT scans were done. Because of the ionizing effect of radiation. In other words, it transmits energy to tissue. One of the things that happens with that transmitted energy is it ionizes molecules and atoms, and when that happens, that induces or increases the risk of cancer. Some of those cancers are going to be fatal. So exposure to radiation increases the risk of cancer in the exposed patients, and some will be lethal. Diagnostic radiology studies, unlike therapeutic radiation, almost never use enough radiation to cause direct effects like hair loss and skin damage. And even therapeutic radiation, they try to adjust the dose and the mechanism of giving the dose to minimize those effects. At any rate, one way of expressing the risk of these radiology procedures is to convey the increased chance of death caused by a cancer that's resulted from the radiation exposure. Now, to convey that risk, you give it in a percentage, but you have to remember that the chance of you dying or anyone dying from cancer for a given patient with no exposure to radiation whatsoever is on average 42%, or 420 per thousand. In other words, the chances of me dying from cancer are 420 per thousand. Radiation exposure adds to that risk. It is of note that there's really no way to tell whether the cancer I get down the road is actually secondary to administered radiation or some other cause or spontaneous. So, how much energy is deposited in tissue? And these are a bunch of confusing metric system terms that can kind of set your head spinning, but basically, how do you measure radiation? How much does a patient receive during radiology procedures? There are a lot of terms that can be used when measuring radiation exposure. Let's basically talk about millisieverts here. 1,000 millisieverts is 1 sievert. 1 sievert is the energy required to accelerate a kilogram through 1 meter in 1 second. So if I had a kilogram and I accelerated it through a meter in a second, that would be 1 sievert. 1/1000th of that is a millisievert. All right. For energy of radiation used in diagnostic imaging, but not necessarily other types of radiation, either lower or higher in energy, but generally the level of energy used in diagnostic radiology, a rad or radiation absorbed dose is equal to about 10 milligray, which is another radiation absorbed dose, which is equal to about 1 rem, which is a Roentgen equivalent man, and all those equal about 10 millisieverts. Radiation doses vary with the type of procedure and with the type of scanner. Ultrasound and MR, as I mentioned before, don't use ionizing radiation. They still use energy, and there are some risks, but we're not going to talk about those here. The risk of death from cancer from those other modalities is felt to be nil or pretty close to it. All right. X-ray, CT scans. What is the radiation from them? How about MR and ultrasound? Well, as examples of radiation doses, the chest radiographs and extremity radiographs generally result in what's called a minimal exposure, or less than 1/10 of 1 millisievert. Pelvis radiographs and mammography result in a low exposure, 0.1 to 1 millisieverts. Single pass abdominal CT and bone scans result in a medium exposure of 1 to 10. Maybe we will measure, routinely try to measure our exposure in our department for CT scans, and generally CT scans are 4, 5, 6 millisieverts, something along in that range. And I'll talk a little bit more about that in a second. Multipass CT scans and whole body PET scans result in what's called a high exposure of greater than 10 millisieverts. Now, how does that radiation exposure relate back to that cancer risk I was talking about before? Well, to figure that relationship out, you really have to extrapolate from data on atomic bomb survivors. And the reason is, the lower the dose, the less the effect, the larger the population you have to study to prove the effect. And the amount of extra cancer caused by low doses necessitates studying thousands or hundreds of thousands of people. But you can study people that have had higher doses and then look down the curve to see what the effect of lower doses would be. And that's basically what we're doing. So in general, the known proven risk increases linearly from doses of about 100 millisieverts up. And the risks below the level from 100 millisieverts up are really based on a linear no-threshold hypothesis that lower doses result in less additional cancer risk, but still it's a line all the way back to the origin where you got zero cancer risk from zero exposure. Some people contest that model. They say that the curve goes over or under the linear line. In other words, a little radiation may be a good thing. There are actually people that advocate that. They say that a little radiation may prevent you from getting cancer. I'm just saying. There are other people that say a little radiation, that the line starts out higher and flattens out. But what I'm going to talk about here is basically this linear no-threshold hypothesis, which seems to hold sway in the scientific community to the greatest extent. Now, one thing to keep in mind is that radiation is to infants and to children, to adolescents, is not the same as radiation exposure to someone who's 80. One of the main reasons is the kids' cells are turning over faster, and the likelihood of them developing cancer is probably higher innately. Plus, they've got their whole life left in front of them, so some little bit of damage here that might cause cancer in 5 years, who cares in a 90-year-old that's going to be dead by then? It's a lot different story in a young patient who won't be dead by then and will live to have that cancer and then live to die from the cancer. Okay. So the likelihood of radiation causing something bad to happen increases in children. They have longer to live. The tissues are a little bit more radiosensitive. Compared to an adult at age 40, a child is 3 to 4 times more likely to develop a lethal cancer, and an 80-year-old 3 to 4 times less likely to develop a lethal cancer. Okay. So I haven't told you all that. As a generalization, and this is probably true within an order of magnitude, which is a pretty broad, true, but the generalization is the additional risk, and remember your background rate's 420 per 1,000, your additional risk of developing a lethal cancer from radiation exposure is about 1 per 1,000 per 10 millisieverts. So if you're 40 years old and you have a CT scan done that goes through your abdomen and pelvis a couple of times and you get about 10 or 12 millisieverts of radiation, that's all pretty much true, then your chances of dying from cancer go from 42.0% to 42.1%, or 1 per 1,000, over the course of your life. So, that may sound like a huge number to you, and that may sound like an insignificant number for you, but that's the number that it is. Now, some experts discourage discussing specific numbers with patients for whatever reason. They think the patient's going to get confused, they think it's going to keep them from getting a study that they should have, they think it's going to make them dismiss a risk that they'd otherwise take seriously. I don't know. Anyway, the experts that say things like that, they prefer to use terms like negligible for less than 1/10 of a millisievert, and these are risk terms, minimal or extremely low risk for less than 1 millisievert, very low risk for less than 100 millisieverts, for less than 10 millisieverts, low for less than 100, and moderate for greater than 100. And that expresses the risk, not the radiation amount that I talked about earlier. For most radiology procedures, with the exception of the multi-pass CTs or prolonged angiography, the additional risk of developing lethal cancer is going to be less than 1 in 1,000. CT manufacturers are working very diligently to reduce radiation doses, especially in pediatric populations. Protocols and scan technology should soon shift, if it hasn't already, pediatric CTs from a routine of 5 to 10 millisieverts, probably down to the 1 millisievert range per exam. And typically, most radiology departments are very conscious of pediatric radiation dose and make efforts to decrease that dose as best they can. Okay, what about radiation in pregnancy? Okay. In pregnancy, the risk of developing a lethal cancer for the fetus is less than that for a small child. And there's no evidence for risk of fetal anomalies, intellectual disability, growth restriction, or pregnancy loss, not fetal cancer, but these other things, fetal anomalies, intellectual disability, growth restriction, pregnancy loss, for anything less than 50 millisieverts. Remember, 50 millisieverts, that's a lot. I mean, that's like a bunch of CT scans. For higher doses, like over 50 millisieverts, for whatever reason, I mean, you'd almost have to have a radiation accident to have greater than 50 millisievert a pregnant woman exposed to that kind of radiation. But for higher doses, during the first 14 days of pregnancy, there's an all or none phenomenon. The fetus is either going to die and undergo abortion, or it's going to survive without any adverse sequelae. In the 4 to 10 week period during organogenesis, you can get intrauterine growth restriction and congenital malformation at doses greater than 50 millisieverts. Now, fetal exposure, not maternal, but fetal exposure, is typically negligible in examination of maternal body areas other than the abdomen and pelvis. For example, a woman with severe shortness of breath who's pregnant, who you think has a PE, and who you have to know. You're always presented with a quandary, but as of this moment, typically the VQ scan, the pulmonary, the CT angiogram of the chest to rule out PE is typically going to need to be done even though the patient's pregnant. There is controversy about that, but in general, imaging parts of the woman apart from the fetus result in negligible fetal exposure. All right. Now, an excellent source for this is this Radiology Info website, and you just go to the tab safety, and it's written in lay terms. I mean, it does a better job than I do explaining all this stuff. And either for a clinician or for a patient, you can send your patient here, and if your patient has questions like, how much radiation am I going to get for that chest x-ray? What's that going to do to me? Should I be worried? I've had like 9 chest x-rays over the last month. Am I going to start glowing in the dark? Those kind of questions, you can usually send them to this website, and I think that should help answer a lot of your questions, or a lot of their questions. So what's my summary? Summary is, contrast-induced nephrotoxicity, for the reasons I've said, it's probably been overestimated. Current contrast materials, it's going to be pretty low. Usually radiology departments are kind of on top of this. They monitor the creatinine. They'll institute hydration protocols in cases where there's an elevated creatinine. They'll advise not using contrast material if the creatinine is high enough, etc. Idiopathic hypersensitivity reactions, you may never see one. They're usually taken care of in radiology. They may come up for you as an ordering physician if the patient said, last time I had that contrast, I got sick. And you may say, well, what happened? Well, I got flushed and I felt nauseated and I vomited. Well, that may happen. That's a chemotoxic reaction, not an idiopathic hypersensitivity reaction. The patient may have that response again, or they may not. But that's not a contraindication to contrast material in the future. In other words, they're okay in that case. On the other hand, if you say, well, I'm going to sign you up for a contrast CT of your chest, and they said, I can't have that stuff. Last time I had that stuff, I had to go to the unit, my throat closed off. Then you got an issue. Okay. Gadolinium containing contrast. Again, radiology departments are going to be on top of this. If somebody comes in for an MR of the brain and they're on dialysis, you're probably going to get a phone call, or they're just not going to do it with contrast unless there's some overwhelming reason to do so. Finally, radiation exposure, significant concern. I'll say one other thing about this radiation exposure, and that is where this will probably first impact clinical practice, in addition to the pediatric cases, particularly pediatric oncology patients where they get a lot of exposures, is younger people that have renal stone disease. Before this whole issue arose over the last 5 to 10 years, people with renal stone disease were getting repeated CT scans often whenever they had an incident of renal stone disease. The trend is really to veer away from that. Now, of course, the CT scan is going to show you the size of the stone, it's going to show you where the stone is, it's going to document that the stone is the cause of the patient's flank pain and hematuria. But if you have a 32-year-old who's had 3 stones in the last 2 years, who now comes again into the emergency room or into your office with flank pain and hematuria and says, I have another stone, they have another stone. And usually you want to treat them maximally and conservatively with IV hydration, the other medication, all that stuff, and make sure that they've given every opportunity to pass that stone before you go imaging them. Even then, you may want to think about involving the urologist and figuring out whether there's something other than going directly to imaging or that requires imaging. They may still need the imaging to know whether it's an 8mm calculus that's way up at the UPJ or whether it's a 3mm calculus down at the UVJ. But at least this is an area where the evolving concern about radiation exposure has diminished the readiness with which we order CTs repeatedly on patients with flank pain and hematuria. So radiation exposure, there you go. And again, that radiology information site is very helpful. Thank you very much for listening to this lecture. I hope you've enjoyed it, and I hope you find it of use in your practice. Thanks.